Sup, guys? Welcome to the PT Good Podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
Kane, we have a riveting topic today, and that topic is directional preference. So, Kane, why don't you give us a good intro? Why don't you let us know what directional preference is and where it fits into our system?
All right, so in our previous episodes, we already discussed motor control, strength deficits, and activity reconditioning as some of our main deficits that we prioritize. However, directional preference to me, and I think for Mark as well too, takes a priority and actually supersedes those three deficits that we just discussed. There's a reason why we have an individual episode for this and this alone. And that's because directional preference is just so powerful. If you have discovered that your patient has it, directional preference to me is a deficit, just like all the other things that we talked about. However, it also means that if they have it, it can be quickly addressed. It is something that usually provides rapid changes in their symptoms. So that is one of the things that I am almost always keeping an eye out for. Because if you have rapid changes in their symptoms, you have confirmation for your intervention. This is something that we talked about previously, where in PT, you don't always get confirmation. Sometimes you need to wait a few days, weeks, your standard 6 to 8 weeks before you get to see neuromuscular or actual strength changes, right? I don't know, Mark. Directional preference, I see a change within seconds, minutes,
Yeah, easily.
you know?
Yeah,
So,
exactly.
that to me is why directional preference supersedes the other deficits, is because of how quickly you can identify, apply an intervention, give that to them for their home program, and get confirmation to make sure that whether or not you're on the right track. And that just makes it so much easier to just know, okay, we're going down this path, or nope, this just isn't it for me. And so then you can explore the other deficits that we talked about.
Yeah, and just as Kane said, like this, the directional preference, if it's present, it's an it's an impairment on its own. It's something that must be addressed, and in our opinion, it's the first thing that needs to be addressed. And you may see someone has directional preference, and you may think that they have other impairments or deficits like fall into the other categories that we described, such as motor control, and you begin to address the impairment that you start to address the directional preference, and these other impairments and deficits start to clear up. Maybe you thought it was a motor control type issue, and you start to address whatever some directional preference they have in their knee, and they start to squat better, start to move better, then they have less pain. Well, look at that. That's something that when we talk about motor control, something that takes time to really get the stick. When if you have a directional preference that's present, maybe it's like a couple visits, and then that suspected motor control deficit was actually just it was an underlying directional preference and they need to be addressed. You got it addressed. Couple visits, their pain settled down. Now you got on track and you're starting to address the issue a lot quicker than if it was something else.
So you actually touched on something that I think is really, really important, which is when you address a directional preference, a lot of times their symptoms may manifest in other ways, in other deficits that you think that you should be finding, right? So just like Mark said, maybe their motor control has decreased. Maybe they're having pain with a specific pattern. Maybe their strength has significantly dropped. I know like one of the main things that we can tend to see is for an extremity, if they have a directional preference, they're not going to have very good strength or motor control. And the question is it truly a strength / motor control issue? Where it's what we're seeing. But
Right.
if they respond to a directional preference, maybe it doesn't necessarily mean that those are the true deficits. Those are just the symptoms that we're finding.
Typically,
So
I'll refer. I mean, we can use the term inhibition, right? Something's going on, something's causing this. Yeah, we can call it a strength deficit, right? But it's really just because, yeah, something's going on, something's not moving how it's used to, and it's because, yeah, they have. Is it? We notice they have directional preference, and because of whatever's going on, and we'll talk about this a little hypothetically, what Kane and I, think could be affecting this and why someone has directional preference. But yeah, there's something going on that's throwing things off, and certain muscles are inhibited, and because of that, they're not able to perform a certain task.
Yeah, I mean,
Rather than a
to be
true
honest
strength
with you,
deficit. Yeah.
yeah, and like the concept makes a whole lot of sense, right? And I usually
Hmm.
explain to my patients, like, if your body's in pain, you're not going to want to be able to produce a lot of force. Your
Right.
body does
It's
not
not going to
want
let
that.
you. Hmm.
Yeah, it wants to pump the brakes to make sure that you don't hurt yourself, right? Whether or not you're actually
Yeah.
hurting yourself
Yeah.
is a different story. But one of the big things is, like, if you are in pain, if you've sprained your ankle, you're going to have a pretty hard time being able to run and jump at max capacity, like how you want to for a competition, or if you even just want to go train or anything like that. Your body just doesn't want to because it's in pain. So the same concept really falls into directional preference. Why would your body want to be able to do those things when it thinks that it's in danger? So
Yeah.
these are the things that I think that are just so important when we address directional preference, because you could be hitting all these deficits. And sorry, but if they have this deficit, you may be addressing it way slower or not having any effect at all. And
Yeah.
I'll be the first person to
Right.
say, when I didn't buy into directional preference, I was like, okay, I'm just going to keep hitting this. This thing isn't
Right.
real. And lo and behold, when you actually fall back into it and you're like, okay, you know what? I'll give it a try because nothing else has worked. And then it finally works and you just kick yourself, because it could have been that simple. You could have just saved that patient so many more hours,
Right.
so that you could have given them like maybe weeks back that you didn't. Right. And that's why
Hmm.
I check it out first and foremost. And whether or not it is or it isn't, it still is so easy to find out. Like you get through it within, I don't know, like one session, two sessions tops, in my
Yeah.
opinion.
Yeah.
It's pretty quick and easy, right?
Oh yeah, yeah, exactly. I mean, like you had mentioned, if it's there, you will. There's going to be a noticeable, significant change rather than something where someone's coming in and it's just, oh, it's a little bit better each time. Like you had said, like you may not be having an effect at all with whatever intervention you're applying. Maybe it's just natural history running its course, and then you get towards that like 6 to 8 week mark, and all of a sudden the patient's like, oh yeah, no, I'm feeling back to normal. Time had the effect, probably not the specific intervention you were applying. Whereas when we have directional preference, these are quick, rapid, sustainable changes that we're noticing, and they're reproducible. So when it's there, it's there. And yeah, we hope with this episode we are able to help people identify and then follow through with that too, more quickly and appropriately treat patients. So, Kane, one thing I wanted to bring up too is the, we're using the term directional preference, and my background's in MDT and Mackenzie. Kane utilizes that a lot too. He's had many mentors that are credentialed or even a diplomat in that. So the one thing we wanted to just discuss is that when we say directional preference, we're not specifically talking about MDT. MDT Mackenzie's, it's an evaluation system that can be used as a treatment method when it's appropriate, and directional preference is part of that. But when Kane and I talk about directional preference, we're simply referring to some kind of movement that causes a reduction in pain or an improvement in symptoms or a improvement in the pattern of symptoms such as centralization. So at some point we may use MDT terms, which we'll discuss, but we just want to emphasize MDT is utilizes directional preference, but we will be talking about directional preference at sometimes within the context of MDT, sometimes outside of the context of MDT. But this episode isn't a specific Mackenzie type episode. So Kane,
And what
yeah, go ahead.
one of the things I do want to add to that is that directional preference is not exclusively
Right.
an
Yeah.
MDT term.
Hmm.
It is something
Yeah.
that the school of thought is like utilizes heavily, but it is a concept that is utilized throughout all of physical therapy. So
Yeah. Exactly.
that way we understand that regardless of the school of thought, or even if you don't have a specific school of thought that you adhere to, that you can still utilize this principle, just like motor control, just like loading or loading strategies or anything
Hmm.
like that. All of these things are not tied to a specific school of thought, so it's totally fine for us
Yeah.
to, for everyone to
Yeah.
use it.
Yeah.
I
Yeah.
think it would be a disservice if they didn't, to be frank with you.
Exactly. Yeah. So speaking
All
about
right.
thoughts, Kane, what are your thoughts on? We're talking about directional preference. Why do people have directional preference? Do you think is this a structural anatomical type thing? Is it strictly just based on movement? Like, what do you think's going on? Why are people able to move a certain way, have a have a significant reduction in symptoms, and they move a different way, their symptoms can come back just as quickly as they were reduced? What's going on there? What do you think?
I have thought about this, but I don't know if I have put enough like time and hard thought into it
Hmm.
to come up with a clear definition, aside from the fact that like it just works
Yeah.
and
Yeah. Yeah.
that's all that I truly care about. But I think that for directional preference, the biggest thing that my kind of sticks out in my head is almost like an activity reconditioning. It's like you're moving them in a pattern that they haven't really moved in before. You've probably heard of the seesaw analogy, where it's like you do something a bunch of times in your day-to-day life, and so you
Hmm.
move them in the opposing direction, and then it starts to balance out that seesaw and they start to feel better. Part of me buys into that, but a lot of it to me is like, okay, so you have kind of worn out aspects of this joint from moving in this one direction. So when you move it in the other direction, it gives it a break.
Yeah. Yeah.
And then you're kind of like, okay, we start to feel better. We got a little bit of a reprieve.
Hmm.
Now our symptoms are starting to calm down. We continue to do this day in and day out. And then it finally completely calms down and we let time do its thing. That is how it kind of fits and makes sense in my head. Whether or not that's like true or not is a different story. I have a really hard time buying into the structural obstructions or anything like that. There are cases where I could see it, like maybe like a meniscus or something along the lines of that, but other than that I just have a hard time buying into the obstructions that a lot of other people may say happens with a directional preference.
Yeah.
What about you, Mark? What are
And
your
you're referring
thoughts?
to when you say something in a way like an actual structural something limiting the movement, right? There's something within the
Yeah.
joint that you go to move it and it stops it. Yeah. Okay.
Yeah, I think like the only thing, like I said, meniscus or maybe big maybe
Yeah.
is like a chondral lesion, like a flap of some sort
A
that you just
flap.
need to get. Yeah, that's
Yeah.
the only thing I can really think of
Yeah.
where I'm
Yeah.
like,
Yeah.
yeah, that I can buy.
Which you say flap, that makes me think of meniscus too. But yeah. Um,
Yeah, yeah.
yeah. So I mean, I definitely take. I think you and I have a similar definition. I mean, I don't try to get anatomical with it just because I don't think we have any kind of evidence to say that, yeah, there's some kind of tissue, some piece of matter within the joint that's restricting movement. So I take more of it's more of a presentation, qualitative approach. Like, okay, we have this individual. We know that when they move a certain way, their symptoms improve and they stay improved and they consistently improve over time, and we're able to um, consistently improve them with this movement to the point where their symptoms are abolished, and then we're able to move them into positions that were previously causing their symptoms and they don't have symptoms anymore, right? So yeah, I think this is a directional preference. It's a pretty specific presentation, clinical presentation. So I don't really get hung up on the anatomy, anything like that. I just focus on the identification portion of it and then addressing it appropriately. I mean, with the MDT background, we can use the term derangement, which is a clinical presentation that demonstrates an improvement in symptoms or centralization of symptoms in response to repeated movements or loading strategies, which is essentially what I'm describing, right? So, but derangement is like the first couple words, a clinical presentation. There's nothing that says it's, a piece of disc or fat or synovial tissue getting in the way. We can think of that hypothetically because typically in these presentations, and we'll talk about this a little bit more, you see movement loss. Is there an actual lesion, something occupying space that's causing this? And is that lesion able to become reduced or, give way so you can move more? I don't know. I don't see at least right now, I don't see the clinical value in having to set our sights on a specific anatomical structural explanation. I think the clinical explanation is perfectly valid and it it's identifiable and said, and we can treat it with directional preference exercise. So yeah, like I said, I haven't, I've thought about it. I think that qualify of clinical presentation definition fits more. Is there something structurally or anatomically occurring? Maybe. I don't know. But I don't, I haven't, I've kind of got to the point where I don't think about it too much
It
because
doesn't
I don't know
really
how much
matter
value
that
provides. Yeah,
much.
exactly. I'm just kind of like, maybe. I don't know. Maybe it's the plica, like stopping your knee from if I don't know, man. Whatever. Yeah, like I'm not sure. It doesn't matter. Whatever. You straighten your knee out a couple of times. It got better. All right. Anyway, so yeah, those are my thoughts. So, Kane, what
So
do you think?
you
Yeah, go ahead.
you touched on derangement, right? And this is something that a lot of people come into. It's a bit more controversial, right? So
Yeah.
you mentioned the term derangement, and one of the big identifying factors for derangement that you didn't mention actually was
Hmm.
a rapid change in symptoms, right?
Yeah.
Like you would expect that to have like a pretty significant change. And as one of my mentor would always say is we are looking for Cadillac changes, not Camry changes. Nothing small.
What's wrong with
We
Camrys, man?
want big. Hey! Don't get me wrong. I
Okay.
love Camrys, good old reliable cars. Let me tell you. So, I, I think that that is such a key distinction
Right.
that it when we have that discussion of whether something is a derangement versus whether something is a hypomobility, I think that's really interesting to have that discussion in nuance, and everyone views it a little bit differently too, so Mark, why don't you tell the listeners what's your take on hypomobility versus derangement, and
Hmm.
do you even view it as hypomobility, or is it just simply a derangement to you when they
Yeah.
respond?
Yeah, I mean, so like I said, typically we see movement loss, right? So can we use the term hypermobility for that? You could say that, right? They're not moving as much as they typically move, or that joint, whatever that body part doesn't have as much movement as the person typically has. Again, I mean, I think we get caught up in the terminology here. When I think hypermobility, to me, and I don't know why I said I don't know if we have like a set definition for this in a textbook somewhere. I think of a restriction of movement that has occurred over time that is going to take a not a longer amount of time that's been going on, but a long amount of time to improve. I think of something like, making actual structural tissue changes, stretching. I mean, that's a debatable topic as well, but let's just use that as an example. When I think derangement, I think something that, okay, this person, they can only move their shoulders so much, and then they start to do thoracic extension, and now they went from like 110 degrees to 160 degrees. Obviously, we're not making like an actual structural cellular level change within 10, 20 repetitions of an exercise. So that, for whatever reason, that's where my mind goes. Again, it really, to me, it's like it's the timeline, right? So hypomobility, yeah, I mean, by definition, if you have a derangement, you have movement loss, it's hypomobile. Um, but yeah, getting tied up in the terms like that, I just look at what the presentation is, and then what we know is gonna what the appropriate management strategy is for that presentation. I know you're, I mean, we go back and forth kind of half jokingly about hypermobility derangement. Where are you at with that?
Yeah, so I actually fall into a very similar camp, unsurprisingly.
Okay.
Um, so I've I qualify the two of them so it makes more sense in my head. Right.
Sure.
So
Okay.
derangement, like I said, is a rapid responder. I expect there to be fast changes. I expect their prognosis to be better because of how quickly the changes are coming on. Right. Hypomobility is like, oh, okay, it's getting a little bit better, a little bit better, a little bit better over time.
Yeah, sure.
And it's
Okay.
gradual. Right. So that is something that I'm like, okay, maybe I need to adjust my expectations, or probably should, to better prepare the patient for their prognosis, right? When a patient sees that they are making a very quick change and they're like, oh my God, what just happened? This is
Yeah.
magic. That's when I know, hey, we kind of hit the jackpot. Like I said, directional preference is like a home run.
Yeah.
If it is there, it is a middle fastball that you
Yeah.
better be swinging on,
Yeah.
right? So
Like prognostically, it's
if
so good. I mean, centralization is better prognostically than directional preference, but like you said, if it's there and you know it's there and it's sticking, you're home run.
yeah, like
Yeah.
you gotta
Grand
nail that,
slam.
right?
Hmm.
What if it's for a joint, if it's for spine, yeah, I when I say joint, I guess I mean
Extremity.
extremity.
Yeah.
But yeah, all of these things, like, they can respond to directional preference. You just have to discover it. You just have to take the time
Hmm.
to see and exhaust that deficit, just like how
Yeah.
you'd exhaust any other deficit,
Right.
right?
Yeah.
So that's typically how I view it. And hypomobility is something where I'm like, okay, we've tried other directions, can't find it.
Hmm.
It's just
Hmm.
not there. So when
Yeah.
you've tried that, you don't need to keep like trying to find something. It's just not there.
Exactly.
Right. I think some of the other deficits are a little bit more interesting because you can revisit them and continue to make progress there when you weren't able to do so before. I do not notice that with directional preference. It is either there or it isn't. Like, it
Yeah.
is very black and white in
And
my
that's
in my experience.
yeah, and that's part of the skill and the identification, which we'll talk about in a little bit, is knowing, okay, do we have directional preference? How much of an improvement do we need to see, and in what ways does this person have to improve for it to be enough of an improvement that we say, okay, there's directional preference, this is a derangement, we're sticking with this, and this is the route we're going. So, Kane, what about
Yeah.
subjectively, like in the history? Like, is there anything, any certain factors, anything the patient's telling you that you start to think, okay, this person may have directional preference?
Yeah, I think the biggest things that I'm usually looking for are the acuity or the chronicity of the symptoms, because usually for directional preference, it's not going to be something where they have a mechanism of injury per se. It certainly can be the case, but doesn't have to be. A lot of times, in my experience, I usually see that these patients are having like an insidious onset. It just comes out of nowhere. They're usually just like, yeah, I was good. And then all of a sudden one day, like, I just can't move my arm as far, or it hurts and it feels weak, etc. And it's like, it's kind of ongoing. So I usually will notice more of a chronic or insidious onset versus just a straight up acute type of thing. It may pop up out of nowhere, but it usually isn't caused by a mechanism of injury, at least not that I typically see.
Yeah,
Sometimes it
maybe,
does, and I've seen it,
uh,
but not always.
maybe no specific trauma or something like that.
Yeah. And
Yeah,
I think like the other thing is like a sudden loss of range is like pretty key, like
yeah,
and it's not just like, oh, I can get it up there and it's painful.
right.
It can be the case, but a lot of times it's more or less like, I can't get
Just
past
can't do it.
this.
It's
Yeah.
obstructed per se. Yeah,
And
yeah.
if you give them overpressure, it hurts more.
You're not moving
So
it either. Yeah, exactly. Yeah,
yeah,
something's
yeah,
not
that
letting it
is
go.
that is usually what I will see for subjectively, where I'm like, I think
Hmm.
that we should probably start thinking in the lines of directional preference first. And like I said, super, super fast to rule in or out. And so it doesn't really hurt to do when you're going through your actual physical exam.
Yeah.
But what about you, Mark? What do you usually ask for or look for during their subjective for something like this?
Yeah, sure. So one of the main things I look for is variability. If someone comes in and they're describing symptoms to me that I think in some way they're demonstrating directional preference, I'm asking them one single question is that, hey, do you ever have days or at least long periods of time where your symptoms are significantly less or in some cases absent? And if they're basically, are they having good or bad days? And if they answer that question yes, at least from in my experience, that significantly increases the chances that they are having directional preference. Essentially, they're telling us that there's some kind of pattern to their symptoms. There's something that they're doing that's bringing them on, and clearly there's something that they're able to do that their symptoms are absent. Like I said, for a certain period of time. Um, in most cases, I mean, they're coming to us because they haven't been able to. Maybe they have identified that pattern, but they haven't been able to get it to stick, keep the symptoms away. And so that inherently is the variability, right? So I said we have good days, bad days. It's in this case, it's our job to identify that pattern and then teach them how to manage it. Some other things I look for,
So
like yeah, go ahead.
so I was just gonna say you mentioned that there's usually a pattern. Do you also
Yeah, yeah,
notice that there is a pattern where it is inconsistent? So it's not a
yeah.
pattern that you notice that you can track,
Hmm.
but it's a pattern where you're like, this isn't adding up.
Yeah.
This doesn't
So
make sense.
yeah, so again, the variability, right? And sometimes, like you said, inconsistent. Sometimes it, yeah, it's consistently inconsistent, right? So it's like, yeah, I
Yes,
don't know.
yes.
Sometimes it just acts on its own, and sometimes as we begin to move these patients, we can actually see it's pretty consistent. It's just maybe the patient was able to pick up on that, but in some cases it is pretty consistent. The person's like, every time I go to reach behind my back, every time I go to try and like straighten my elbow when I'm at the end of a push up, that's when I get the pain, and it's there each time I do it. I can show you right now, and it's going to be there every single time I do it. I mean, first off, that's a great baseline that we can use to use as a comparable sign. But second off, yeah, you get some consistency there. But then you have, on the other hand, you have these patients where it's a bit more inconsistent. Maybe they come in like, hey, today's a good day. Look, I can straighten my arm all the way. I can reach straight behind my head and it doesn't hurt. But listen, like if I would have came in 2 days ago, I wouldn't have been able to get my hand like up to my forehead, or I wouldn't have been able to, straighten my arm more than like up to like 10 degrees, something like that. So if someone's coming in and I'm doing a subjective and they're answering questions like that, it kind of it's we know there's a pattern. It As we begin to question them more about maybe when they notice the symptoms are better, when they notice they're worse, we can start to kind of see what this pattern is, and it really, in my opinion, or at least in my experience, increases the chance that they're going to have directional preference.
It's so funny that when we just discussed the different details that we're getting from our patients, we gave very conflicting information where it's like it can be insidious and chronic, but it can also be acute,
It can
but
be,
most of the
yeah,
times it's not acute.
yeah, like
Sometimes it follows a pattern, sometimes it doesn't, but
sometimes it could maybe be like this on certain occasions. But like if you had
yes.
a flow, if you had a diagram or a table, and you had chronicity, you had um like symptom duration, you had like all these kind of things laid out for people with directional preference or who want to use the term, we talked about derangement earlier. Those boxes, everything's going to be yes. It can be any of it. It can be any kind of duration. It can be any kind of chronicity, right? The symptoms are variable. The duration of times the symptoms last, everything's variable, right? So, but the um, I guess the thing that is consistent is that it is variable, right? So that this is when it can get a little bit when we're talking about a subjective exam, we need to be pretty specific about the kind of questions we're asking, and we talked about this in a previous episode. Where's your pain? When do you feel the pain? How long's this? All these kind of things are going to help us to guide us where we go with our objective exam and farther down the line, how are our treatments applied?
Now, I think it's really funny because you're like, the thing that's consistent is that it's variable. The other thing that
Hmm.
is certainly consistent with directional preference is that it is a rapid responder.
Hmm.
So, definitely want to add that in there. For the most part, people with directional preference are going to change very quickly. So that is something that if you notice that, that is usually really signaling to you that you want to move into this direction, and that is what's going to at least explore it, experiment,
Right,
and
right.
investigate a little bit further, because you never know. And I think with the topic that we have that we've been discussing so far is because there are so many contradicting things, it can showcase itself in a bunch of different ways. It's kind of telling us, hey, we should probably check this more often than not. And that is how we know whether or not it's present. It's a quick and easy thing to investigate and to rule in or rule out. So that brings us to our next topic of Mark, when exactly are you testing for directional preference?
Yeah, I mean it's worked right into our objective exam, like Kane and I discussed earlier. Typically, we're seeing movement loss. So right away, when you're looking at your gross range of motion screen, you're already starting to develop a case for directional preference, right? Perhaps like if we use shoulder as an example, they're limited overhead. They're also limited reaching behind their back and reaching straight backwards. Okay, this is a common presentation we see for people who have directional preference with shoulder issues. We're already starting to build a case for directional preference right there. Um, yeah, and then we can also begin to look at, farther down our objective exam, things such as manual muscle test and inhibition due to pain. But the movement loss is really a huge thing that will clue you into directional preference right off the bat. Speaking of movement loss, Kane, let's say you have someone come in, they you think they have some degree of movement loss. Like how do you think if you think they have movement loss, you think they have that kind of obstruction to movement? There's certain things you're doing that can help you identify that they truly do have that movement loss.
What am I doing to determine that? Is that what you're asking?
Yeah, things you look at, like let's say you're doing your movement screen, uh, they move their shoulder. How do you know if it's true movement loss?
Yeah, so there's a couple of questions that I asked just to clarify. So if a patient raises one arm and the other arm doesn't go as far, I usually ask them, so what are you feeling? What's stopping you? And is it painful? Does it feel like you can't go anymore? If I manual muscle test them, is it like weak because of pain or because it's just straight up weak? The other thing is like if someone is super mobile or bendy, whatever you want to call it, they may move within normal limits. And if you look at that at first glance, you might just be like, oh, like that's totally fine. Right. But you don't know until you ask, hey, does this feel normal to you? Can you usually go further than this? Or is this limited for you? And then the other thing is compare to the other side. I'm not saying that both sides need to be perfectly symmetrical for there to be no issue. That is not always the case. Asymmetries are totally fine to have. The other thing is you want to make sure what happens when I push a little bit further. So I usually double check with the patient. Okay, so when I push and give you a little bit more pressure, is it changing your pain? Is it increasing it? Is it decreasing it? Is it staying the same? All that is valuable information. And that helps you figure out, like, hey, is this a directional preference or is this something that is another deficit that we need to address?
Right. Yeah, especially in the
Is that
extremities, like the degree of movement loss can be subtle, right? So maybe you have someone reach overhead and they can't see how far they're reaching. They just think, especially if they have a lot of mobility, like in the case like Kane was talking about, maybe they can't even notice that maybe it's just like a 5-degree loss. And you go to add that overpressure, it reproduces their symptoms and you can't move them farther compared to maybe a case where you are able to move them farther. Right. So these kind of things are important. Like Kane talked about comparing to the other side, getting the patient's feedback. Does this feel normal to you? Do you feel like you're limited in any way? And also, adding overpressure so you can get a feel for, is there a restriction of movement in that joint?
Yeah. So, Mark, you mentioned that you're checking overpressure, but
Right.
which ranges are you typically
Hmm.
checking, and how are you kind of adding in that overpressure? Because, like,
Yeah.
I feel like for directional preference, this is something that really gets lost a lot of times. Is
Hmm.
you're just checking the common ones. You
Yeah,
check the
exactly.
things that you routinely do, right? So,
Hmm.
what do you usually look at?
Yeah, I mean, we can start top down. Cervical, I'd be right off the bat, I'm adding over, not off the bat, sorry, but if I'm looking to add overpressure, retraction is typically the movement's going to, that's going to benefit people. So in certain cases, we have to add extension. So initially, I'm just adding some retraction over pressure on the chin, straight back, hand on their upper back, just for counter pressure. And then if I need to, extension, just tilting the top of their head back while moving their chin back like that. Gives me a feel for how their neck's moving. If we go to shoulder,
What about
sorry, yeah,
Yeah, I was
man,
just gonna
I'm
say, what
getting
about for
there, man.
shoulder?
I'm
Because I
getting there.
know that is
Yeah.
one where everyone just looks
Hmm.
at what
Yeah,
they look at
gross movement.
flexion, they
Yeah,
look at
exactly. Yeah.
ER, IR,
Hmm.
abduction,
Yeah.
and I don't even
Which,
know if they do IR very well. It's just like
yeah,
the
with the,
Apley scratch test, and we call it a day. You know.
that's, man, I don't even know what that is, but but I'm just gonna
Listen,
carry
Mark,
on, all
we
right?
call that residency train,
Yeah,
baby.
right. But yeah, I mean, so you said flex, abduction, ER, right? Um, yeah, everyone checks that, right? Those are the function based movements, right? But when we're talking about directional preference, we got to look at all planes of movement, right? Especially in the shoulder, where extension and internal rotation are varying degrees of either of them is going to typically be what's going to help. We got to see what happens when they reach back. We got to see what happens when they reach behind their back as well, right? In certain cases, you can look at straight horizontal adduction, varying degrees of flexion, but I think the most important things to look at shoulder are where they're limited, which is, or where they're functionally limited, or where they notice, which is typically going to be some kind of elevation, usually flexion. And then we need to look in the direction of what's going to typically help them, which is going to be extension, internal rotation. Elbow, typically people are spending their days in flex positions in their elbow, so usually extension is limited. And when we're talking about, excuse me, overpressure for extension, yeah, proximal to the elbow joint at the wrist, push down. Like we're really trying to test these joints. We're giving them a good amount of pressure to get an idea. Okay, is there really movement loss here? How about for like
So
lower? Yeah, go ahead.
I was just gonna ask,
Yeah.
and this is my own practice. I don't know if other people will do it this way too. Like I'll check flexion, abduction, range of motion for the
Hmm.
most part, like actively, right? For extension, I usually will just start to move them. Like I
Hmm.
usually just do it passively. I don't check it a whole lot actively. I don't notice that it makes a huge difference. A lot of people are going to have limitations in extension actively. Your shoulder just usually doesn't move in that manner. So I usually just grab them by the wrist
Hmm.
and then just start cranking on them and see how it moves. Like that is going to be a much bigger indicator for me in regards to their joint end feels. Like what does this feel like? Does
Yeah.
it feel like it's freeing up? Does it feel like it's just stuck? Does it reproduce their pain? Any of these things, all of that provide a lot of good information about how you should kind of best proceed, because it really does just clue you in on whether or not you are headed in the right direction. Directional preference, direction,
Yeah.
nice.
Yeah. Yeah. I love it.
Whether you're moving down the right path or not, right? But
Hmm.
how do you usually check extension? And if you do the same thing for that, do you do the same thing for IR as well too?
Yeah, extension, I'm stabilizing like superior aspect of the chromion. I'm on that dorsal aspect of the wrist because usually I have them in relative internal rotation, so their palms facing away. And then I just push into it. Because, like you said, if they extend on their own, it's not like a movement people do a ton. So maybe they lean forward. Maybe they just like, not that they can't do it, but it's just different for them. So I want to get in there. I need the information. So, like you said, top of the shoulder, back of the wrist, push up. Okay, how's it feel, right? And you can, I mean, you can use that as an, if you determine that they have directional preference there, you can do that as a, as an intervention as well. So yeah, getting the hands on the person just to feel out the joint, see where that restriction is if it's present, get the feedback from the patient. Is there any kind of symptomatic response? That's typically how I would do it for shoulder. Do you want to move on the lower extremity? Like, see, you test hips a certain way, knees a certain way.
Yeah, for knees, I am usually checking passively.
Hmm.
I pretty much just move them. It's part of my objective testing. I check extension first and I see if the joint is springy. We talked about this
Hmm.
previously. That joint needs to hit terminal knee extension. You need to get hyperextension for the most part, unless, well, depending on the
Yeah.
age group that you're working
Hmm.
with. But you need to make sure that you are getting good extension there. That is the whole point of the knee. When you start to lose that extension, you're losing a lot of like the screw home mechanism. And those things are things that your knee wants to do. So I definitely work on overpressure with that just to make sure, see how it feels for me, see how it feels for the patient
Yeah.
too. They're both very different details. Moving them into flexion, I need to make sure that we're getting that soft tissue approximation. If we are not, if we are getting stuck by the joint, that could mean a handful of things. Maybe it's a directional preference. Maybe it's just a very arthritic joint that does not want to move any further.
Hmm.
And that gives me more information on whether or not I want to address it with more
Hmm.
mobility or if it's something that we just need to work
Yeah.
around if they're functional, you
Which
know?
movement do you find is the typical movement that helps people if they have directional preference for the knee?
Extension 1000%. It is so rare that I find someone that I need to give flexion for. I think it's happened twice
Hmm.
while I've been practicing, but extension is just so key. And sometimes you can add in tibial, internal, external rotation, whatever you want to do. I, for the most part, just stick with
To
straight
get
extension.
the full end range extension, that rotation you're talking about.
Yeah, like
Yeah.
you're gonna get most bang for your buck if you are just starting off with this. Then just staying purely extension or flexion and just keeping it as straightforward as you can, that tends to yield the best results
Hmm.
from what I've seen. I hardly have to go in other directions or have to add any of that other stuff to see
Yeah.
improvements. Maybe you
Yeah.
might need to close it out, but not what I
Right.
usually see.
Exactly. And like what Kane was saying there, especially if you're listening to this, and I mean, we're talking extremity here. I'm sure most people are familiar with directional preference for the spine. But if you're starting with this and you're hearing us talk about directional preference for the extremity, like you can really think of it as there's a lot of similarities in the extremity to the spine, right? So if we think lumbar spine, it's you bend a lot. Usually extension helps. Let's look at shoulder. People reaching overhead a lot. Rarely they're reaching backwards or behind their back. So that opposite movement of flexion, which is the extension and turn rotation, usually what helps. When Kane was just talking about knee, extension typically helps. If people are sitting, it, their knees usually bent. How many times a day are they getting to end range extension in that joint? Rarely. When I was talking about elbow, you know, usually when you're doing stuff with your arms, your elbows are bent. How many times a day is someone forcefully extending their elbow and testing out the limits of that joint? Rarely. So now if they all of a sudden if they have to do something or they're getting stiff into that extension, yeah, that's as we get more mobility in that direction, that's typically what's going to help. So and
Yeah,
like we can
and
finish it off with hips, like same thing, sitting. You can get tight there. Um, Typically extension is what helps, or repeated hip extension, half kneeling, standing, whatever it is, whatever position works. But it makes sense. Like we said, we draw similarities to the spine. All these joints um, react similarly when it comes to having directional preference. So, I said if you're starting out with this kind of stuff, keep it simple. Understand the patient when they're talking to you subjectively. Match it to your objective. Find a movement loss and attack it.
Mark, I don't know if you realize you actually added another layer of complexity here where you said change the load going into half kneeling, right? So directional preference can change depending on how you are loading the joint too. So sometimes a joint does better offloaded, sometimes a joint does better with load. For knees, for the most part, same thing with hips, both are load bearing joints. I usually see better responses with those joints doing their job, giving them the load and the feedback that the joint wants as it continues to move.
So,
Shoulders are typically
yeah,
offloaded and they usually respond better without any additional
right.
loading, right? Sorry, what were you
Yeah.
going to say, Mark?
What do you want to give us an example? Let's go back to knee. Like I said, it's a load bearing joint. right? Typically, it can handle that load, so we can work into the movement restriction under load. What would it look like? What would a exercise to restore extension look like loaded? What would one look like unloaded?
Yeah. So unloaded, I typically will just check out on my own when I just passively move them or mobilize them, whatever you want to call it,
Hmm.
into extension.
Yeah.
Sometimes I get a positive response and I'm like, okay, cool. We can certainly explore this a little bit more. And other times I get nothing out of it. Or sometimes it gets worse, right? So I still continue to load them to check, because just because I've investigated a directional preference unloaded does not mean I've ruled it out if I haven't loaded them again. Right. So unloaded is them on their back, me pushing on it. You can do a couple different variations, like if they have their leg propped up on an ottoman or a chair and they're pushing down on their knee, that would be unloaded. Then you can progress that. You could have them maybe sitting on a chair and their leg straight out in front of them, and
Hmm.
they like their heels on the ground and they're just pushing on their knee that way. That's semi loaded. The last one is usually them standing, and I have them with their butt up against the wall so that they can maintain their balance, and they just push on it that way. You're increasing the amount of load bearing that that joint is taking.
Right.
So that's how you can kind of rule it in or out once you've gone through those different progression.
Yeah. So you
So
have this
I think,
progression there, and like, what's the purpose of this progression? How does it fit into someone who has directional preference?
yeah, I mean, you're literally just trying to find out what exactly the joint wants or needs, right?
Hmm. Yeah.
Like the
Gotcha.
joint is going to tell you if they have a directional preference and you just haven't found the right loading that it needs. It's going to tell you it's either not going to respond or it's going to get worse.
Hmm.
Usually if they don't want to be loaded and you give them a loaded directional preference exercise, they're going to get worse. That
Yeah.
is usually the case, almost always, every single time,
Yeah.
because I jump and skip steps where I'm like, oh, I worked on offloaded, especially for the knee. I'm like, oh, you're good. Let's just head on over to the wall.
Hmm.
90% of the times, it doesn't bite me in the butt. The other 10% of the times, I'm like, ah, crap. All right, let's go. Let's go to the chair, see how you do with that, and then gradually start to work them up. But I'm pretty much going based off of like stats and like how prevalent like I'm seeing these certain things where I'm like, okay, usually I see more people respond better to fully loaded. I'm gonna go there right away.
Yeah.
Not the correct
Especially.
way.
Uh-huh. No, no. I mean, like, you start. You need a starting point, right? So,
Yeah,
like you said, if you start with insufficient load, there's probably not going to be effect. If you start with too much, then maybe their symptoms get worse temporarily. But regardless, it gives you information either way. Um,
for sure.
I think a good point too, like if someone's starting out with this, to try and develop a starting point is to match it to when the person has symptoms. So if we stick with Nian as an example, I had two cases recently. I had one person coming in, they had knee pain when they squatted, right? It was essentially loaded flexion bother them. Okay, weight bearing position. They had full flexion range of motion. They were limited in extension. So I know their symptoms are prevalent or presenting when they're weight bearing. We're going to start with weight bearing, and the reductive maneuver ended up being a standing repeated knee extension. On the other side, I had someone come in. They could squat, they could run, they could jump. They were fine. They only had lateral and anterior knee pain when they crossed their foot over their opposite knee and sitting. Unloaded, okay. Yeah, could we have gone loaded? Sure, but this person's telling me they can run, jump, do whatever they want. Fine. They only have symptoms when they do this specific thing. Okay, let's start unloaded and see what happens. We started there, it got better. That's all we had to do, right? So if someone's starting out with this, use the skills that you've developed over time already. Just listen to the person, take the information they're saying. It's like I said before, match it up to the objective information, and then there's your starting point when it comes to where you're starting, loaded, unloaded, how much force you're doing. So you
It's
talked about,
funny.
yeah, yeah. Hmm.
I was just gonna say it's funny that for those two cases, or especially the
Yeah,
last one, your patient pretty much told you the answer, right?
yeah, yeah,
They
yeah.
told you what exactly they needed to
It's
do
sometimes it's
to help
that
improve their
simple. Yeah,
symptoms.
it's just like, hey, this is when it hurts. Um, it said you go through your objective, and if we talked about, this is a the pattern recognition identification is something Kane and I have discussed in previous episodes. I'm sure earlier in this episode, but like as you go through this process and you start to identify people's directional preference, it's really going to smooth things out for you. You're going to see things and be like, oh, I've had 20 other cases like this. I know where I'm going to start. This is the response I expect. And then if it doesn't, depending on the response, you're going to know where to go. So we discussed force, loaded, unloaded. The other thing you can do to progress is just repetitions, right? So this topic is interesting because, especially when it comes to the spine, I'm sure people, if you don't have a lot of exposure to this, you heard, 10 reps every this many hours, something like that. But depending on the person, it's fluid. You can modify it. So maybe you have a case where someone's coming in, they have moderate to high symptom irritability. It's probably not necessary to start with that, 10 rep range. Maybe do two, maybe do three, and you just see what happens. And like Kane talked about before, the hallmark of this patient presentation is the rapid change. 2, 3 reps, that might be enough where the person's like, hey, I don't feel as much tingling, or okay, I can feel my knees straight, or I can reach farther backwards. Great, okay, then you can start to build off that. Now, if you have someone coming in that has lower symptom irritability, and maybe the movement loss is more subtle, it's not as glaring, okay, maybe they need more reps. And if the reps aren't causing any kind of symptomatic resolution, maybe more force from there. But that's another variable that you can alter depending on the present patient presentation to start to address these limitations.
Yeah, and I think that really does go in hand with our objective exam where we're trying to find out whether or not they have a directional preference, but it also goes for when you're dosing your patients for when they're at home, right?
Yeah.
You've found like the amount of reps, the force, and all these things that your patient needs to help to reduce their symptoms. Now make sure that you're giving them the same thing for when they're at home.
Mm-hmm.
You've already gotten the answer, you've done all the work, so make sure that you're dosing it appropriately.
And how do you
The one
explain
thing,
yeah? Well, how do you explain to people how to do that then? If you're prescribing a home program, they've come in for the evaluation, they've demonstrated a response to a certain amount of load, certain amount of repetitions to a certain movement. How do you explain to them what's the initial management look like before they come in for their first follow up?
yeah, so I straight up tell them where, like, hey, it took us 2 to 3 rounds of 10, for example, to notice a substantial change, right?
Mm-hmm.
So I want you to do the same exact thing when you're at home. Try 2 to 3 rounds and then see how you feel. You should be able to reproduce the similar type of symptom reduction that we experienced in the clinic today. If they aren't able to do that, that could be additional information. Maybe it's just one of those things where you thought you had a homer
Yeah.
in the first half, and then later on you're like, oh crap, maybe it's not directional preference.
Yeah.
So that can definitely be the case, but usually I don't notice that that's the case. If you are getting a very dramatic change, I can almost certainly say that there's got to be some component of directional preference
Right.
at least. So that's usually how I dose it. Do you do something different?
No, not typically. I mean, it depends. If it's someone who started out high symptom irritability and by the end of the session they're low, then even if they're able to tolerate a lot more reps or more force towards the end of the session, then I'm more specific about how I want them to address it, right? I tell them, listen, we were able to get this amount of movement back. Your symptoms reduced by this much. Um, I'll give them more information on how to manage it. Like, I want you to start with this movement, progress to this movement if you are able to. This symptomatic response is going to guide their management. So I make sure I explain to them if centralization was present. I explain to them what was going on. Teach them to look out for it. Teach them to look for worsening symptoms or signs that they need to back off a little bit too. But in the case of someone who's like a low moderate symptom irritability, straightforward case, yeah, like this is what happened today. Your movement got better. Your symptoms got better. They should continue to get better. But the main thing is going to be avoiding positions or movements where you have worsening of symptoms and continuing to perform the exercise we did today to reduce or abolish your symptoms. And the frequency is usually depending on the patient. If it's high symptom irritability, maybe it's more frequent but less reps. If it's a lower symptom irritability, maybe it's more reps but less frequent. Yeah, it all depends. But the main goal is that they have a movement that they can go home with, that they can use to manage their symptoms initially. And then as they're coming in and we're reassessing, we can progress the movement, change it if we need to.
Yeah, so that actually ties in
Hmm.
to us utilizing these directional preference exercises as our treatment. So
Right.
when you send someone home with the exercise, what exactly do you do on your follow-up visits? I know,
Right.
like you already said, we want to be able to reduce their symptoms, but then what else? What are you doing after the fact?
So first and foremost, when they come in for the follow up, I'm asking, okay, have you done the exercise? Depending on their answer, it dictates the rest of the session. But typically they have, right? So okay, as a result of exercise, have your symptoms changed in any way? If they're better, okay, how are they better? Do you still have numbness or tingling? Do you still have back pain, neck pain? How's your movement been? We'll get a response from there, and then we start to ask, okay, how often have you been doing the exercise? What happens when you do it? And yeah, depending on the responses there, we go from there. And then right um, at the beginning of this reassessment, after we've talked to them subjectively, we're reassessing our baselines, right? So typically, we talked about a loss of movement, symptom location intensity, and then we're comparing it to a functional limitation that they have, right? So we have a couple baselines right away. Right after that, I have them do whatever movement that they're doing at home. Okay, show me how you've been doing it. And then I compare the baselines again afterwards. If they had a positive response, and it's continuing to get better, I can see it's better. Mechanically, they're better. Subjectively, from their end, symptomatically, they're better. Um, I might not be doing much else after that. Maybe we can test some of their movements. Maybe we can progress force a little bit. But if they're getting better, they've we can see it's better. They've told you it's better. It might just be more of the same. Now, another presentation is someone who comes in and maybe it's something like, okay, I'm doing the exercise. It feels good when I do it. It's good for a couple minutes after, but it comes back and, I'm like 5 or 10% better compared to last time. That's not a big enough change for me to say, okay, good, it's better. You keep doing the same thing. At that point, we're starting to look at, okay, this person need to do more reps at a time? Do they need to do the exercise more frequently? Do they need more force? Typically, in those cases where they're unchanged, they usually don't need like a different direction or movement. Usually, it's more force or more reps. They just need to do a higher dosage or intensity of the movement that they were doing. But again, the principles of the reassessment stay the same. Where they come in, we're looking at our objective and subjective baselines. We're doing the movement and comparing from there. In the case where someone's worse, then again, we're looking at baselines, we're looking at the movement. Maybe they're doing the movement wrong. Maybe the movement was just too much for them. But we're talking where you can always have room to modify the variables that we talked about, force, reps, and then if they're still worse as they're doing in front of us, then maybe we have to change direction. Maybe we have to regress forces. Maybe we need just a different position to do the movement in. But that's typically what the reassessment looks like for me. Like it's very, I mean, we talk about standardization, we talk about keeping things consistent. Your reassessment should be very similar to your evaluation. Your baseline should be staying the same. I mean, you can get other baselines as you're going forward, but we got the baselines at the first visit for a reason. These are the primary impairments, primary limitations that the patient had, and this is what we want to know is getting better as we're applying the intervention. Anything else you look at, Kane, when it comes to reassessment? You do it any differently?
No, I think you kind of hit the nail on the head. The biggest difference that I will usually make, and it depends on their presentation,
Mm-hmm.
but I usually notice that the follow ups are going to go a handful of ways. The first one, the patient comes in and they're like, wow, I feel like 80-90% better.
Mm-hmm.
That's awesome, right? You did majority of your job. And so what I'll usually do at that point is I will test the stability of their symptoms. I have them continue to do the things that they found provocative. If it's no longer provocative, I'm going to make it harder. I need to make sure that the things that are provoking their symptoms, there's a progression. Like, can we continue pushing that envelope and have it not be so provocative? That's going to tell me whether or not, like, how much more do we need to close this out, right? Like, I don't want to send them home and they're like, I feel 80, 90% better. And they're like, okay, cool, just go home, keep doing this, and then like pray for the best. I want to still make sure that I'm testing it to make sure that it is like that's going to be resolved. Right.
Yeah.
So
So
sometimes they just need more time. They need more reps, something along the lines of that. And then it goes completely away.
yeah, so in
The
that case where like the symptoms are coming in for that are responding to directional preference are almost resolved. Like you said, you're hooking into it more. You want to see how stable it is. You're trying to see if the symptomatic response is similar to when they came in. And if that tells you, let's say there isn't a symptomatic response anymore, maybe they just have a little bit of movement loss or 80, 90%, they just don't feel like they're all the way there. Do you begin to, and if you're going to talk about this after, we can go through the other scenarios that you have laid out. But like in that case, if they're basically almost better, like do you begin to add other exercises, or what's that look like?
Yeah. So the big thing is depending on the chronicity of their symptoms, right? Like if you've had inhibition for a long period of time, if you've had hypomobility, is it fair for us to be like, oh, well, your shoulder moves a whole lot more now. You're good.
Yeah, yeah, yeah.
I think that making sure that they're able to move in that newfound range of motion is going to be beneficial for them. Just to check it out, make sure that you are conditioning them and getting their tissue to adapt to whatever new demands that they're going to be placing on it. So make sure that you're testing them in the newfound ranges of motion, that you're actually pushing them in that regard. I think that that is definitely helpful. You can call it motor control. I don't know necessarily if I would call it that in my own head. I'm just like, okay, well, you haven't moved here before in like a few years. Let's try it. Let's see what that feels like. Get you some reps, some more volume here. And over time, your body's going to get used to it. I just want to make sure that you're actually moving in a way where I'm like, okay, this is good. This is fine. I don't foresee any issues with it, instead of just sending you home and then after that there's still a problem,
Yeah,
right?
so you're
So
testing the stability of their symptom reduction in that regard
yeah,
when it's
yeah. So
appropriate, right?
oh, for sure, for
Yeah.
sure. I think the three main categories are the first one that I mentioned, where it's like, oh, they feel a whole lot better. Awesome. We check out the stability. The second one is the category that Mark mentioned, which is like there's no improvement or minimal improvement. What do we do? Right. And then we kind of talked about either having to ditch directional preference, and that's another deficit instead, or maybe we need to change some of our variables. The third one is something that I find that a lot of people kind of get mixed up on a couple of different or in a couple of different ways,
Okay.
which is they're 75, 80% better, but they aren't continuing to get better. Right. And so,
Mhm.
what do you typically do when you hit that point?
Yeah, so at that point, and we talked about this in the beginning, maybe and we're assuming we've progressed forces, we've tested everything out, right? There's no remaining directional preference per se, correct?
Yeah. Like,
Yeah.
how do you know when you've
Right, right,
exhausted?
right. Okay, so we've gone through our full force progression in the direction that we're working with. We've explored variations of the movement. Um, we've gone in different directions, and they're largely unchanged. If they're like that for more than like, I don't know, 2, 3 visits, I think we're at the point where we can say we need to move on to a different treatment strategy. So again, we will collect our baselines. We will apply a different kind of intervention, whether it's something like we talked about before. Maybe they end up falling into a different category of classification. Maybe it's a motor control type thing. Maybe it's like we talked about activity reconditioning. Maybe it's a loading force reduction type deficit. We start to look at those categories versus just working to directional preference. And again, we have our baselines and we're applying intervention, we're comparing, and it just might be the directional preference. We've exhausted that. We've kind of gotten to our limits with that, and it's just not there anymore. So that's simply how I approach it. I try and yeah, I try not to draw it out too much. Some people go longer. So usually I can see if it's not, like we talked about rapid change, if it's not there within like a couple visits and it's not changing from there, then I don't really see a reason to have to stick with it any longer. Especially like where we really want to emphasize this: quick, rapid, lasting changes. It shouldn't be something where it's like, we've done a certain movement 100 times, and then, then their shoulder range of motion has gotten 5 or 10 degrees better. No, it should be something where we've done 10 or 15 repetitions of this, and they went from 120 flexion to like 170, right? Not so. Yeah, if they're better, but they're not getting any better, give it a handful of visits, and then we got to go a different, down a different route. Timeline wise,
Yeah,
you give it any
yeah.
more or less time, or
No, I'm pretty much right around there. I feel like, especially if I am expecting it to be a directional preference, it should be fast. Like we talked about this previously. But I think the biggest thing is when that happens, don't be afraid to move on. It's
hmm
okay. You've gotten a lot out
yeah,
of
like
it.
right,
75-80% symptom reduction is huge, right? Like you don't need to be afraid to move on. But on the flip side, when you're investigating directional preference, also don't move on too fast when you're first
hmm
going through your eval, because you might just miss it. It is not always easy to find. So be patient with it, but also know that it's okay that you've exhausted it, that you can go somewhere else and see if you can continue to make more progress that way.
yeah,
There are
right.
deficits for a reason. You need to move through them to make sure that you're addressing the ones that are most relevant to resolving your patient's
Yeah,
symptoms.
and this is something that Kent and I talked about in the past. I want to him saying that made me think of it again. Like if you have identified directional preference, I think Kent and I firmly believe that that impairment, directional preference on its own, has to be addressed. It has to be you have to run its course regarding applying interventions until the end, until you're not getting any more benefit out of it, um, before you really go down another route. So if it's there and you're getting that quick rapid response, you got to hammer it. I think Kane and I both think you have to, like I said, you have to go the entire way with that, run through it. I've seen a lot of clinicians where they identify directional preference. They know the person gets better with a certain movement, and then they're like, okay, I know that gets better, and then they start doing a bunch of other exercises and all kinds of different movements, and then they start spinning their wheels. Well, you just had the answer right in front of you, and then you essentially abandon it, right? So yeah, stick with it, and like I said, even if you get to the point where it doesn't close out the present issue, you've gotten a large chunk of relief out of it. It just means you go a different direction from there. All right, Kate, before we wrap up, anything else you want to add?
Yeah, there is one last thing that kind of goes on top of what Mark just said. When you are checking out directional preference, you think that it is involved, don't add in a bunch of other things. Don't just toss things in, because you won't actually know what is working and when it stops working too. Right. So that's where, like, you want to make sure that your variables are controlled for, your ducks are all in a row. So that way, when directional preference fully resolves their issue, or if it plateaus, and then you can move on. That is how you can start to make sure that you are addressing deficits within a like hierarchy, and that you
hmm
are addressing the most pertinent ones, like the lowest hanging fruit, if you will, before you move on to the other things that usually take up more time, like motor control, loading stuff, or reconditioning. All of those are going to take more time than directional preference will. So just make sure that you are controlling your variables when you are working through this deficit.
Yeah, perfect. Well said. Okay, so just to summarize, like I mean, just like Kane said, directional preference it's on the top of the list when it comes to what needs to be addressed regarding impairments. It falls into categories such as motor control, said strength, loading tolerance, but directional preference is going to beat all those out in terms of how long it's going to take to get better. So why wouldn't you address something first that's going to take a couple visits versus the other categories that we know it's going to take longer? We talked about subjective identifiers such as sudden loss of range of motion, and again, the variability and the rapid change that you can see with directional preferences. Someone comes in and they say, good days, bad days. They have a noticeable movement restriction, and you go into your objective exam and you're able to confirm those, and you have them move a certain way, and their symptoms change dramatically, whether it's better or worse. Those are, I mean, there's signs of directional preference. There's something there. It needs to be addressed. When it comes to implementing it as a treatment, stick with it, let it run its course before you start adding in all kinds of other movements like Kane just said, because you're not going to know what's having an effect. It's necessary to stick with usually a single movement exercise, have them come in, reassess, and then follow the steps in terms of progressing repetitions or force or doing alternative movements and gauging the symptomatic response so you know you're on the right track. Okay, well, that concludes today's episode of the PT Good Podcast. We thank everyone for listening. Remember to leave us a like, subscribe to us on whatever platform you're listening to us on. We thank you for listening. Hope you enjoyed, and we will see you on the next episode.
Misty, love you. Bye.